I would like to introduce our moderator for this panel, Colleen Chavla. Colleen directs the Alameda County Healthcare Services Agency, which comprises the county's behavioral health, indigent health, public health, and environmental health programs and services. Colleen joined HCSA a mere year ago, bringing more than 25 years of prior experience in the health sector, most recently as Deputy Director for the San Francisco Department of Health, of Public Health. So Colleen, I'm going to hand it to you.
Thank you. Hi, good morning. Thank you, Wendy. So as Wendy said, our panel here is comprised of 4 expert individuals who have varied and ranges of experience and perspectives related to homeless seniors. I'll do a brief introduction of the panel and then give a little bit of context, building a little bit on some of what Linda said around what the county's doing around homelessness, and then I'll turn it over to the panelists. So our 4 panelists are, and the full bios are in your packet, so I'll just be brief on the introduction of the panelists. The 4 panelists are Elaine DeColony, who is the Executive Director of Everyone Home, and Everyone Home is leading the collective impact effort to end homelessness in Alameda County. LaRue Williams is the Director of Homeless Services at St. Mary's Center, a community of hope, justice, and healing that serves at-risk seniors and preschoolers in the heart of Oakland. Robert Ratner is the Housing Services Director at Behavioral Healthcare Services, which is part of Healthcare Service Agency's Housing Solutions for Health team that focuses on the centrality of having a place to call home for overall health and well-being. And Tangerine Brigham, who is the Chief Administrative Officer for Population Health at Alameda Health System and works system-wide on population health management and partnerships to address social determinants of health. So just a little bit of the framing of the discussion. You heard a lot from Josh on making the case for why health should be a consideration in prioritizing individuals for housing. And you heard from Linda about what the county's doing around the affordable housing bond. Linda mentioned the Homelessness Council. So recently the county endorsed Vision 2026, which has several goals for, it was a 10-year vision, and it has several goals to achieve by 2026. One of them is to eliminate homelessness. So the county brought together a homelessness council. The council, as Linda said, comprises many of the county departments that touch homeless services, such as the Healthcare Services Agency, the Social Services Agency, Community Development Agency, probation, and others, really to coordinate our own response to homelessness so that we together can leverage our experience, our funding, our efforts to really make a concerted impact on eliminating homelessness in accordance with our vision. So the council's also meant to align us with our collaboration with cities. So improving the collaboration with cities in alignment with their municipal roles. The county's role is really about providing safety net services, healthcare services, and social services. City roles really relate to public safety and sanitation, and the intersection of those is where we work together on impacting homelessness. So recently, last week, 2 weeks ago, the county passed a 3-year homelessness action plan. So what the action plan does is confirms our annual ongoing investment of $83 million a year, specifically targeted to homelessness, and makes new investments of $90 million over the next 3 years to end homelessness, for a total 3-year investment of over $340 million. We've really looked at it in 5 areas of impact: preventing homelessness, providing outreach, providing health and supportive services, and providing shelter and housing, and then creating a coordinated system with the overall goal of providing an additional 3,000 individuals or households housing from this new one-time funding at the end of the 3-year period. So we're really proud of that and really excited to be partnering with cities, community-based organizations, and others to help us achieve that goal. And that's really what this panel is all about, is around partnerships and the collective impact effort to address homelessness. So I'll turn it over to our first panelist, Elaine DeColony, in a moment. The panelists are each going to offer perspectives on their role in the effort to end homelessness. And at the end, we'll have some time for question and answer from the audience. So at this point, I'll turn it over to Elaine.
Great, thank you, Colleen. Good, as Colleen mentioned, Everyone Home is leading the collective impact effort. We serve as to end homelessness, and we serve as what's called the backbone organization. Huh?
Please talk directly into the mic.
Okay, thanks for that. Is that better?
Yes.
All right. Yes, as Linda mentioned, our generation and technology, I'm nervous. I have to run the PowerPoint and talk into the mic, but I'm going to pull it off. So we are the backbone organization to serve the collective impact effort, which includes Alameda County government and its departments, the cities and their work to address homelessness, the nonprofit service providers and nonprofit developers seeking to end homelessness, as well as people who have lived through or are currently homeless, and advocates working on affordable housing and homeless issues, and pulling us all together to work on this issue. And one of the things we have done in the last year is do a 5-year strategic update to the overall plan to end homelessness. And that strategic update sets in place a vision where 5 years from now, no one, not seniors, not families, not veterans, has to sleep outside if they lose their permanent home. And it looks at what the scale and scope of our response needs to be in order to achieve that. And so like Linda mentioned, and all, you'll hear some common things. But I want to start by, in addition to saying there are 5,600 folks that were sleeping on our street in 2017 on a given night, 5,600 folks without a home, and most of them were sleeping on the streets or in encampments or vehicles or places not meant for people to live. And so we do have a huge unsheltered homelessness, a homeless problem, and a big and growing homeless problem. I wanted to mention that when we do the homeless count, and there's already, as Linda, thanks for the plug, said, when you go to the everyonehome.org website, you can sign up to help with the count. It'll be the morning of January 30th in 2019. And we do, in addition to a street count, we do a survey to learn more about people who are homeless. And one of the things we ask people about is how old were they the first time that they experienced homelessness. And you will see, even in this dim lighting for me, that quite a number of folks became homeless after age 50. 15% of the homeless population first became homeless after turning age 50. And so imagine how traumatic that is to become homeless at that point in your life. And so, and then we have a number of people who've been homeless a long enough time that they may have become homeless as young adults or middle-aged persons and are now homeless seniors. So it's a significant portion of our population. The strategic plan update focuses in 3 areas: preventing homelessness. One of the things our data shows us is that for every 1 person we move out of homelessness back into a permanent home, 2 people become homeless for the first time. That is clearly a problem getting worse, and we need to reverse that trend. We need to reduce the number of people becoming homeless and increase the number of people who leave homelessness to a permanent home. And we need to provide for the dignity and safety of people while they are homeless. And that's why we're focusing some on shelter and other services for people while they're homeless. But a shelter bed does not end someone's homelessness. It brings them indoors, but it is not a home. And so this plan and the work of the county and our city partners really calls to focus primarily on providing permanent homes. And you've heard about increases in investment and from the county, and the cities are also stepping up. We will need to expand our capacity. The $83 million the county spends plus tens more millions by the cities help about 3,000 people a year who are disabled and used to be homeless maintain their permanent homes with services. We really need to be helping about 9,000 people with subsidies and supports to stay housed and avoid homelessness each year. So our capacity needs to more than triple, as does our investment. So we have made some important first investments and big stepping up to the plate, but we've got to step up to the plate even bigger. We estimate that the system we need to keep people from living on the streets of our community will cost us another $228 million a year. The other thing that is really critical to solving homelessness is deep partnerships with people who have been or are homeless. It's their expertise and wisdom that will help us design effective responses and housing people want to live in and services people want to use. So we have continued to work on partnering at the county, city, nonprofit level, and we can improve our partnerships there, but the real improvement we need is with collaborating with those experiencing homelessness. We also need aligned public policies, and so we need to continue to advocate for supporting public policies that build more homes and keep people housed, protect renters in their housing. But everybody in this room is someone or knows someone that has faced the loss of their housing because great rent increases or sales of buildings. The strategic plan, which will be up on our website at the end of next week, also focuses on subpopulations, including frail seniors, and sets a target to end unsheltered homelessness among frail seniors by the end of 2020. It also looks at veterans and families and persons with serious mental illness. But we agree with the case Josh is making, that if we focus on some populations with critical needs and achieve victories, we make the case for ending homelessness for all folks. And so we're asking cities and counties to adopt this as the umbrella plan, as they did with the original Everyone Home Plan in 2007, and then come up with local strategies that are appropriate to their roles in homelessness. Colleen described some of the focus for the county, and cities have different responsibilities, and developers do different things than service providers. And so you can ask your organization or coalition to adopt the Everyone Home plan to end homelessness. You have in your packet a flyer that describes coordinated entry. It is a commitment to prioritize the most vulnerable. And you will see that we and help them get both interim assistance as well as yeah, I was already on that one. As well as permanent housing. So that's a graphic about the system, and we'll have some time to talk more about that. And then these next two slides are really data-heavy slides, and I've only had one cup of coffee, and so I don't know about you guys, but I will maybe unpack these in our discussion, but it really looks at where seniors score in the vulnerability index around housing and what kind of issues seniors bring as they come into coordinated entry. And so we are getting increasingly sophisticated in our ability to understand folks' needs, what their experience prior to becoming homeless was, and what kind of housing will help them. But again, I want to support another assertion Josh made in his conversation earlier, is the most important thing is to listen to the person that needs homelessness, to talk to people, and engage them as human beings, not data points, because it is a human being that needs to move into a home, not a number. And that's what we're all working on together. Thank you.
Hi, can you hear me? Okay. My name is LaRue Williams, and I'm Director of Homeless Services at St. Mary's Center. This is timely in that our emergency winter shelter actually opens on Monday. And so the first slide is going to talk about some of the things that we see. A frail senior was dropped off at our winter shelter by their children. The children said they could not cope with their parents' declining health, mental status, and incontinence. Another scenario that has been lived, attempted family discharge from a boarding care to winter shelter to save money for the 5 months of operation. Senior had a long history of severe mental health and behavioral health issues. Something else that we have seen and probably will see, a hospital discharge of an 84-year-old out-of-county patient who was living in a car with their son. The senior was abandoned with high blood pressure, congestive heart failure, and incontinence. And then also a senior that would returned after a 5150. We've talked about the fact that there is a 2 to 3 year, well, 2 and longer year to wait for your name to come up on a wait list for housing. Seniors are doing several things that other populations are doing, not just seniors. Couch surfing, staying in shelters, living on the streets or vehicles as they're waiting for the time to come, for their name to come up. We also have people that are working at night and then they're sleeping during the day because they've made that decision for their safety. We have people that they're doing all of these things, and then they're also living in short-term motel rooms for, a couple of days during the month. They have strategic plans, and then their money runs out, and then they've got a whole plan to sort of make it through the rest of the month. So these are what our seniors are facing. Having access to community programs, they're going through this, and they're going through this in isolation. We are there and we provide services to help the senior. We are, St. Mary's has a really, really robust community center, and because of that, and we also have homeless services, and with that, we are able to provide lots of services for homeless seniors as well as housed seniors. I work with a team of clinicians, SUD clinicians, case managers, mental health clinicians. We have a psychiatrist. We have all of these people, a housing specialist, and we work to stabilize seniors and then also work to eradicate barriers to keep them from housing. It's not just that your name comes up, but we also want you to keep the housing that you've been able to find. Next slide. Make sure I got everything. Okay. We also work with seniors that are housed in our Resources for the Third Age program, and we do things like medication management, AOD stuff with them, strengthening their body, making sure that their housing is safe for them, and then also having them come into the community so they're not isolated in their homes. We've said that for many years that the answer to adult homelessness is a home. And for those that need the skills and resources to keep it. And those are some of the things that we do. Thank you. And just on a broader level, I just want to say that there are some things that also go on when you're homeless. And I haven't heard this mentioned, but being homeless can add 15 to 20 years onto your unto your health. So you can be a 50-year-old and have the same health conditions as someone who's 70 and older. Some of the things that we want to talk about is having housing subsidies. This has been said. Also working with case managers for seniors that are potentially being housed and that are housed, to avoid eviction and to make sure that that partnership is there so that we can provide support when needed. And then also we have a large community population, and we talk about social justice. And so seniors are able to advocate for what they're experiencing. People have an idea of what poverty is or homelessness is. We don't want them to have an idea about it. We want them to actually hear from the people that are going through it. We've got people that are working on master's degrees that are homeless. You've got people that have chronic health issues that are homeless. You've got families out there that are homeless. And unless they mentioned it to you, you wouldn't know. For homeless seniors, we need to consider additional resources to age in place and to plan for transitions to higher levels of care. We talk about access to coordinated long-term support services, access to higher levels of care, age-specific services, access to IHSS. I think this is important. Within shelters, transitional housing, and permanent supportive housing to help deal with those health issues that they're experiencing. Also, food insecurity. It hasn't been talked about very much here, but come summertime, if you're on SSI, you'll potentially be able to receive food stamps, because a lot of seniors, and not just seniors, a lot of people are having to make a choice between medication, food, so hopefully this will alleviate some of that. Also, being healthy in your home, making sure that you're not being injured in your home, making sure you're taking your medications properly, all those things are important. And then also realizing that as you're in your home, your health can change. You might need more assistance. Your ADLs and IADLs might change, and making sure that we're responsive and able to help with that. There are just a couple of things that I just want to say, so I'm going off script a little bit. But I think that safety is important, and the way that we work with seniors and work with other populations that have gone through traumatic experiences is really important. And so the way that we deal with them, the way that we make our areas safe spaces, the way that we make our clients safe when they're with us is really important. One last thing I wanted to say is when we talk about health disparities, one thing I like to talk about is health literacy. That's a big divide. Empowering seniors and older people and other people to say, I don't understand what my doctor is saying. I need to speak up. There are things that I want to say. I don't feel empowered to do that, and giving them the opportunity to do that. So if it's something as simple as giving somebody a pencil and paper, telling your doctor, write down what they say, because when you're in those moments, those things are difficult to remember. And just making sure that you have the right to say, you are, as a practitioner, not working for me, let me find somebody else who's more responsive. Housing is a human right, not a privilege.
So Wendy hi, I'm Robert Ratner with Alameda County Healthcare Services Agency, and when Wendy was orienting me to the clicker, she said there is a pointer, and I have a fantasy that someday I'll be an academic, so I'm going to turn and maybe use the pointer.
Oh, nice.
And I pulled out the mic, so we'll see how this goes. So as I said, my name is Robert Ratner. I work for the Alameda County Healthcare Services Agency. Like Josh, I fantasize as a medical student in San Francisco about writing a prescription for housing. I still don't have that prescription pad, but I do sign check requests. And many times those check requests result in someone getting housed, and recently that happened, and it does bring joy to my work, because I feel sometimes removed from the people we're talking about. Josh also mentioned how important it is to coordinate, and I work for a very big county organization and a county employee, and we all hear about bureaucracy. Well, one of the things that happens in a large organization, we're I think around $700 million, maybe more now, we have our silos, and often it's based on funding sources. So one thing that we've done recently is, it's not an official department, but we've said, we need to work together more, and we said, let's call ourselves Housing Solutions for Health. So up here are logos. So we have, oh, how's my pointer? Not very good. Okay, never mind on the pointer. So Alameda County Care Connect is part of a statewide Section 1115 Medicaid waiver in California, that's Medi-Cal, that allows us to do innovative things for people on Medi-Cal who are struggling to get good care in our healthcare system. They're bouncing around in crisis and inpatient settings and getting crappy care. And many of the folks who are in that situation are really struggling with housing and other economic issues. So Alameda County Care Connect is a part of our Housing Solutions for Health team. It's bringing in a lot of new resources to our community. It's a 5-year waiver, so at the end of 2020, the waiver will be over, and we'll have to figure out how we're going to continue to sustain the things that we've started. The middle logo there is where I started in the county, but the Behavioral Health Care Department has some funding called the Mental Health Services Act, Proposition 63, tax on millionaires, personal income, has created revenue to improve and expand mental health services throughout the state. One of the things that we did in Alameda County is expand our efforts around housing. We created a housing services office. And then last but not least, I see some of my colleagues here. Alameda County Healthcare for the Homeless, they got a brand new logo, which I really like, so I wanted to make sure it was on here. And they get funding from the federal government. They're part of the Community Health Center movement. And Alameda County Healthcare for the Homeless was one of the first healthcare for the homeless programs in the country. It started as a very innovative effort. Many of the people who got it going here were a part of a national movement to address what we now are talking about a lot more, that housing is a fundamental healthcare issue. So kudos to those of you that were involved with healthcare for the homeless in the beginning. We're finally coming around to realizing housing is a healthcare issue. I've learned that it takes 15 years for good things to sometimes happen, like things that we know really work. So we're getting there, a little behind schedule. I'm a part of the group that Wendy mentioned earlier, which I'm also very excited about, the Age Friendly Council and the Homelessness Subcommittee. And without the pointer, I won't be able to do this, but in public health school, we had this parable about where people decide to put their efforts. And the story that I heard, it's based on a proverb that you're standing by a river, so if you think of the arrows as the river, you bear witness to people who are on the street, and we have posters up here now of people who have experienced homelessness or really struggling and maybe displaced from our community. That's the kind of the end of the arrow here. You're witnessing people drowning in a river. Where do you intervene? Do you jump in and help pull people out and address the issues that they're experiencing right then and there? Do you go a little bit further upstream to find out, wait, what's happening here? And I think we really often forget to go to the core problem, that we don't have enough affordable housing for the people that need it, and we don't have our services working well and integrated and coordinated in enough fashion for people that have housing to be able to keep it. So I heard earlier there's a lot of tension around, do we invest more in the short-term needs of people versus the affordable housing and supportive needs? We're going to have the downstream problem if we don't really understand the adequate amount of investments we need to do and behavior change as staff and organizations to do the upstream stuff. So I'm mostly going to talk about upstream work that we're doing in healthcare, not to dismiss the need to help people right now, but we also have to have some folks, and I'm one of them, looking upstream. And so I appreciate that we have a lot of diversity of people here working at different levels. So as a healthcare person, like Josh, I got into housing and started to learn stuff that was really surprising. Thanks. And I wanted to share some of the things that I found that were surprising, because many of you know this, but many of you don't. So affordable housing policy in the United States is based largely on something called area median income. So what that means, if you live in a community that has high general incomes in the population, that the level that's considered affordable housing goes up. So I think you all know we live in an area with lots of wealthy people. The end result of that is what is considered affordable here would be considered a mansion in Texas where my brother lives. So you have to keep in mind when folks say affordable that it's not the people that I was seeing at San Francisco General Hospital who are on Medi-Cal, who are uninsured, living on $1,000 to $2,000 a month. That's this graph in the bottom left corner here, which shows from the National Low-Income Housing Coalition. It shows nationally where is most of the affordable housing getting developed. You can see that at 100% of area median income, which is half of the people are above that income level, half of the households are below, that's where most of our affordable housing is. We have 101 slots for 100 people in that category. Then you go down to the bottom, which is the people I used to see when I was doing more direct service work, living on SSI, people with seniors and people with disabilities. We have 35 for every 100 households. So we got something backward, I think, in terms of where we put our affordable housing resources. And it doesn't show it here, but in Alameda County, the last stats I saw were around 29 affordable units for every 100 people at that income level. You can see in the top left lots of stats on, we have a lot of people at that income level and we don't have enough housing for them. And then there's the fourth point. It comes from the work of the Age Friendly Council. Where are seniors living? Many are living with family, 24% living alone, 5% living with others, and 3% living in group settings. So I'm going to talk a little bit about each of those. I don't know if you can see the bar graph on the right. This was interesting to me because I didn't realize this. It shows where seniors are living within Alameda County, and among the senior population in a city, what percentage is living at this 200% of federal poverty level or below. I was personally surprised that how much of the population in unincorporated Alameda County, the seniors living in that area of our community, are at very high rates of living at 200% or below the federal poverty level. So what are we actually doing? Elaine alluded to this. We have about 2,500 supportive housing units within Alameda County. A little bit more than half of those are Section 8 voucher type thing. We call it shelter plus care for people who are homeless. We call it scattered site because those folks have to go find housing in the private market. I don't know how many of you have tried to find housing in the private market without a subsidy, but finding it with a subsidy is really hard. So unlike San Francisco, we have fewer built up buildings. We have subsidies that people have to use to find housing. We have about 250 subsidized licensed board and care homes through our behavioral health department. And we don't do a good job of promoting what we do. So the flexible housing subsidy pool in LA that was mentioned was started with $20 million. Well, we have an $8 million one between Mental Health Services Act and the Healthcare Services Agency, kind of Measure A and other general funds. And LA County is 10 times bigger. So we're actually doing good work and it's still not enough. We also are investing heavily in supportive services linked to helping people who are homeless get into housing and stay in the housing. And then in the future, big things coming up. If you're a voter in California, hopefully most of this audience approved of or voted for, I should say, Proposition 2, which was money to help homeless people with serious mental illness get into housing. The money is $2 billion of bond funds. My personal goal is that we should get at least $150 million out of that $2 billion, but it's going to require all of us in this room to work together to apply for and come up with good projects. We have, as Linda said, some supportive housing projects in the pipeline. And the last point I wanted to make is that in addition to supportive housing, we have to figure out how the supports can follow the person. I'm a healthcare person. We silo our healthcare services too much. You got mental health over here, substance use over here, in-home over here. We got to figure out how to bring those things together to support people to keep that home, which I refer to as supported housing. So it might not be a designated built unit, but our service system has to adjust to support people to keep the housing that they have. It's a couple of innovative things we're doing, and I know I'm probably over time. So for my colleagues in the Social Services Agency, we've partnered together to create an infrastructure for helping people who are homeless or at risk of homelessness to get a more coordinated approach to, we call it the Bridge IHSS pilot project. So the idea is, and this came from Margot Kuchel's study about homelessness among seniors, a lot of seniors had connections with family members, but family members felt like they couldn't take them back because it was too much work. Well, many of them probably didn't know about in-home support services as a resource to provide care and support for people when they come back into their home. It's also potentially an income source to a family that can help them cover the cost of housing. So we're really working together closely to figure out how that program can be utilized as part of a solution to end homelessness. Happy to talk to folks more about that. And then Michelle, one of my colleagues from my days at Lifelong Medical Care, asked a question about, hi Michelle, about these independent living homes. A lot of people who are living on fixed incomes live in room and board or halfway houses that don't get public money, but there are folks in the community who are building shared housing with different motivations. We have folks that some would refer to as slumlords, and then we have some who are really trying to make a difference in the community. And we have referred to that kind of housing as independent living. About a quarter of the people served in the county mental health system live in this kind of housing. And we're trying to develop an association, not trying, we have developed an independent living association. Website is alamedacountyila.org. And the idea of the association is to establish standards for a quality independent living, to provide training and resources for the operators so they can run a quality business. And we can make sure that the people who we're serving in our programs and are part of our communities are living in quality settings. We've got our first 2 qualified homes on the website, and we're building off of a statewide movement that started here with an idea. San Diego County really took it and run with it. So multiple counties are pushing this idea of creating independent living associations to raise the quality of this type of housing. And now it's Tangerine's turn.
Thank you so much. So I don't have slides for you on the screen. I think there are a few copies that have been circulated. If you're lucky enough to have one of those, if you could share, that would be great. So I'm going to give you the perspective as a provider system. I don't know if many of you have actually, has anyone actually used a facility that's part of the Alameda Health System? You've gone to Highland? No. Good. Yeah, thank you. Please, someone raise their hand. Let's serve someone who resides in this county. Alameda Health System is comprised of Highland Hospital, 2 community hospitals. We are the sole psychiatric inpatient facility. We've got a skilled nursing facility, and we also have several primary care clinics in the county. You know, we serve everyone, those who are insured, those who are uninsured, and about a quarter of our patients are over the age of 60. Most of those individuals are on fixed income. Certainly they're either on Medi-Cal or they're on Medicare. You know, as a provider, we see the impact of homelessness and housing. You know, when you think about what facilitates access and improvement in health, rarely, you'd be surprised, is an actual delivery of care. You know, really the things that impact health are what we call social determinants of health. And the bucket of that is what I call poverty. So if you are low income, if you are homeless, if you have a lower educational attainment, you're more likely to have poorer health status. And so as a healthcare delivery system, if we're really interested in improving health status, we really have to work, as Robert was talking about, upstream with various community providers and others to address the things that bring people to us in the first place. Several years ago, as part of the department's effort to really get a handle on, you know, why individuals were consistently coming to our healthcare delivery system after being treated and discharged, we set up a program called Health Advocates. Health Advocates is a program that is really a resource and referral. So if a patient should come to a provider and during either the appointment that patient indicates that they don't have enough food, or that they have marginal housing, or that they need assistance with an immigration issue, we have a cadre of volunteers, college students, who've been trained to provide resource and referral, and we contract with legal organizations, other medical organizations to provide assistance outside of the four walls that are within the agency. Oh, not agency, health system. The most recent data shows that when we look at why people come to us, 47% of the people who come to us, to health advocates, it's because of housing. That's almost half of the people who say they have a social needs housing. Almost a quarter, it's food insecurity. And we know, and I'm sure that Josh mentioned earlier when he spoke, our ability to keep someone healthy is impossible when they're not housed. We've looked at, we've started to collect, and we're going to be doing this on a more rigorous basis, data from our population. About 6% of our patients indicate that they are homeless or they have marginal housing status. For those that are 60 and older, it's a little higher, it's 7%. So we know that, consistent with perhaps some of the information that Elaine shared of individuals who, over the age of 50 found themselves homeless for the first time, we see that reflected in some of the numbers of the patients that come to us. So what are we trying to do to address this problem? So first, we have always had contracts with licensed care facilities, we contract with motels, we contract with respite and other facilities to provide care for people post-discharge so that we're not discharging someone onto the street. No provider wants to discharge someone onto the street. But we are hampered. We are not the experts in housing, nor do we want to be the experts in housing. And so we really have to partner with, entities and like these organizations here on this panel and others to really address the housing problem. So what have we done in that area? So first, we have actually partnered, and I think successfully, with the Healthcare Services Agency. I'll just give you this little example. We have a committee that meets weekly at our skilled nursing facility and at our largest acute care hospital, Highland. And they meet to discuss individuals who have been in an acute care bed for longer than 10 days. And you'd be surprised at the number of people who are in acute care beds longer than 10 days and they're not acutely ill. So there's no medical need for them to be in an acute care bed. This year, staff from the agency joined our long stay committee to really look at what were the challenges we were facing as a healthcare delivery system, identifying housing options for individuals so that they could be placed in a safe environment so that when they were discharged, they wouldn't be readmitted because their housing wasn't adequate. One example, and this was a great story, right before the Thanksgiving holiday, it was 2 weeks ago, we were able to work with the county to discharge someone who had been in our facility for over 200 days. And I say that is not an anomaly. There are many people who are in that status for whom it is really important for us to partner with organizations on a regular basis. The other thing that we're doing is, we as a healthcare delivery system, in fact, all healthcare delivery systems effective January 1st of next year, will be required to be much more proactive in helping document and identify housing placements for individuals who are homeless, who are discharged either from our ED departments and our inpatient facilities. I'm sure that some of you probably heard the horror stories that occurred in Southern California with some of our hospitals discharging people onto the street, and that resulted in a bill that now requires us as healthcare delivery systems to ensure that we actually know where someone is going, when they're being discharged from the ED, and inpatient if they're homeless. Our ability to comply with that will certainly mean that we'll have to lean heavily on, the county and others. We are moving towards an electronic health record, which essentially allows us to better coordinate our care and to ensure that it is not episodic and that we really understand the health of the population. We are starting to collect and will collect in this new system much more rigorous data on social determinants of health so that we can then use that data to develop interventions and strategies to address those things that individuals are facing outside of access to medical care. So those are some of the things that we're doing and that we are really committed to working with the broader community to address. Because without doing this, we will continue to see skyrocketing healthcare costs for a population that will get sicker and sicker, really due to fundamental problems in our social policy around housing and affordable housing in particular. So thank you.
Thank you very much to all our panelists. I'm going to ask maybe just one question since we're running a little late on time, and then after that we'll open it up for questions from the audience. So my question is that the panel really talked in many different ways about what's being done now and kind of what's the long-term view. Elaine talked about the need for $228 million a year to adequately serve the population. Robert talked about going upstream and making sure that we're doing what we can to prevent future homelessness. And at the same time, and LaRue talked about, and Tangerine, both what they're doing with people who are homeless today, right now, services being provided to people right now. So as we look outside and see unsheltered homelessness increasing on our streets, my question to the panel would be, what would be the kind of top line near-term priorities that you would identify to addressing the needs of the unsheltered seniors on the streets today in terms of housing, in terms of services, in terms of other kinds of programming?
Well, I'll start from a healthcare perspective. An increase in respite housing would be very much appreciated. We have individuals who may need some health care services or some level of clinical support at discharge, but they certainly don't need to be in a hospital. And providing respite, which allows people to heal in an appropriate environment, would be, I think, valuable, and it allows individuals, I think, to then transition as appropriately to perhaps more permanent housing situations, be it either board and care or temporary supportive housing.
I would say one of the things that I think we can scale up the fastest is the flexible funding pools to assist seniors, particularly reuniting with family or friends, being able to move into existing housing units or back with family and giving those friends and family some support, either with services or with dollars, to maintain that housing and provide the assistance. My colleague here described seniors that were being dropped off at St. Mary's because the level of incontinence or their medical conditions were really burdensome on the family and they couldn't manage it. And that sounds callous, and it's also a reality. And we might be able to infuse both services and supports. We need to keep the building pipeline going, but we need to be able to look at things we can upscale pretty quickly. And I would say temporary financial assistance to reunite seniors on the streets with family and friends that may be able to assist them, house them with a little more help.
Anyone else? Okay, so please.
Just more, sorry. I'm just going to say just more housing in general. Also, to sort of follow what Elaine was saying, is that also respite care for families. If you're taking care of a senior, you don't want to drop them off at a shelter to get a break because things are difficult for you. And just housing.
So to avoid, I'll say that too. Amen to the housing. I think our short-term housing, medical respite is an example, but could be adjusted to better meet the needs of the people who are outdoors. I think there's a lot of barriers to folks coming into our temporary housing because of how we structured the physical layout, but also how we have established policies and procedures that make people not want to come indoors. And it doesn't make sense to me that we, in this environment, still have shelters that have vacancies in some communities because people don't want to come in, when we have one temporary bed for every 4 to 5 people experiencing homelessness. So that tells me we've got to do something about the structures and the policies and procedures. And then on my slide, I didn't mention this, so I'm going to slip this in. The SAMHSA, Substance Abuse Mental Health Services Administration, has talked about 4 things we need for recovery. I think there are 4 things we need for wellness. We need a home, which is more than just housing. There's symbolism, there's connection. Home is different from housing. People need community. They need better healthcare, integrated healthcare, and they need purpose. My high dream is that anyone who doesn't have a place to live at least still has a connection with someone that cares about them. And that for me is a community, and then a purpose, a sense of hope that there's something they can give to the world, and that hasn't been tapped into yet. And we don't have enough outreach workers who know what's available and can help people navigate what's available. So I'm going to go one more thing, on the data that, we didn't show this data, but we do a terrible job of helping people access public benefits, in-home support services, CalFresh, Social Security benefits. It's atrocious. And part of that is it's hard to get these benefits. Part of it is they don't have a connection with someone who knows how to help them or what they're eligible for. So to me, big thing is connection. More outreach workers, those of you in the room, whether it's volunteers, whoever, we got to organize and train people, health advocates, that connection is critical.
Great, thank you. So we'll open it up to questions from members of the audience. There's one here and then one back there.
Hey, great panel. Hi, my name's Stephen Knight. I'm the policy director at Alameda County Community Food Bank, and I just wanted to build on something Ms. Williams said and that you just finished with, which is connecting to people to benefits. And starting in June, 48,000 people on SSI in this county are at least potentially available for up to $130 average a month in federal funds, free money for the county. So that's just something that, because the rent eats first, that could have a marginal impact, or certainly it have a big impact on those people. I don't know how significant an impact it can have on the problem we're seeing on the streets, but I just invite anybody who's in the room wants to work on that to reach out to the food bank and help us get as many of those people on CalFresh with these federal dollars.
There's one at the table 7 back there. Oh, maybe not.
I just wanted to say again, you mentioned Highland, and I work with a lot of people that come out of Highland and they have the hospital gown on and they've been put out because they're no longer considered able to stay there. But if there was some kind of mapping you could do to take that person to the next place, especially with a severe mental health problem, sometimes they come in the building and they use the bathroom because they just don't have the proper facilities. Some of them have to have medical marijuana. Are provisions really being made for the mentally ill homeless to have somewhere to go other than to John George and then they're right back again? I just have ongoing people and I really would like to be of more help, but they're bounced out of one place to the next and there doesn't seem to be a place they can just go and be until proper housing can be found for them.
Thank you. I think there was here in the blue.
Can I comment on that comment?
Sure.
Great. I did.
Oh, sorry, I'm sorry.
No. I think we're all thinking the same thing.
Yeah,
If you
we
can
all-
go and then.
Okay. So I want to say that it is important to take full advantage of every benefit and every resource out there. And we aren't quite doing that yet. But I also want to be clear that better mapping to resources will not solve this problem. There are not enough resources yet. So we can spend a lot of time doing better mapping, and we should do better mapping, but we have to be careful that we describe that as a solution. There are not places for people to go from Highland. There are not places for people to rent. And we will not solve it with building or with exclusively with public dollars, which is again why I think Robert's point about connection is important and community. We have to build up the capacity of us to take care of us. And so these reconnections to friends and family are important, and the resources to support those reconnections being successful. So we have to commit to advocate for more resources, as well as better use of the resources that we have. But the real gap is in resources, and we have to be honest with ourselves about that. That's why our plan talks about a $228 million gap to really reduce homelessness successfully. So you'll hear me say that a lot, but it is the reality.
Tangerine.
I don't disagree with Elaine at all. At the same time, the Whole Person Care Project, Alameda Care Connect, which I suspect there's an AC3 person here
Right
in
next
the
to
audience.
you. Right next to you.
Where?
Next
Oh,
to you.
you.
But not in, I don't know if there's anyone in the audience.
I would strongly suggest you connect with Robert after we get off of this panel, because even though we don't have a sufficient amount of resources, the ones we do have, you need to understand what those are for those patients today. And Rob's the guy.
Yeah, so I'll say a little bit about Alameda County Care Connect, I think, to get at your question. One of the big pillars that we have as a goal within this Medicaid waiver is to create something called a community health record. And I think it addressed some of what you're saying, that we have an asymmetry of information. We certainly do not have enough adequate resources, amen to that, Elaine, and we also have asymmetry of information and bad communication. So some of the people that you see may actually be enrolled in a mental health program, but they can't find them because they were homeless and they don't have a phone. But the idea of the community health record is a portal where if you have the right authorizations from a client, someone can look and say, oh, this person is connected to a program, and here's the phone number of their care manager. And if you're seeing them, you have another ally you can work with. So I think tightening up, we use this term safety net. I don't like it, but in this kind of case, the one thing I think about is, can we get away from a net and like tighten? We have big holes because we're not tightening those ropes and communicating. So the idea of the community health record is to make it easier for us to share and coordinate information about what's available, who's already connected, how can we best help them. And I did want to say something about the CalFresh. And that is, we have a project with social services, again, for people on general assistance who are disabled, who need help applying for Social Security benefits. We have some very interesting kind of Josh Bamberger type research on the BART train, but I'm going to share it anyway. The standard GA grant is $336 a month, not very much money. We add a little bit of money to that with healthcare dollars to bring it up to the federal portion of SSI, around $654. There's a couple of interesting things that we found once people go from $336 to $654. Fewer of them are homeless, fewer of them are in jail, and fewer of them go to the psych ER and the medical ER with an extra $300 a month. So a little bit of money can really transform people's situations and their relationships with others. So help people get that benefit and the benefits, and let's advocate for more of what we need to really solve these issues.
Thank you. There's a question back here.
I just wanted to say that we should have a one-step place for all resources for all the seniors instead of going here and there for different information they need. And also I wanted to say that for respite, we definitely need respite care for the family, because most times the patient outlives the family member. So we all need to take a break where we can take care of ourselves, because we all have a human right for housing. So please remember to try to do what we can to help everybody with a one-step place for resources. So the seniors will have to go here and there for information. Please, thank you.
So you just touched one of my, oh.
Finally, thank
you.
you.
I wanted to comment about the one-stop resource. So I think we all need to align, and there's going to be a meeting about that resource that Linda Gardner mentioned earlier, the Dahlia, one portal for affordable housing. But the idea of getting one thing where we put all of our information means those of us that have information about programs have to agree on what is that one place, and we have to keep it up to date. That means we all have to stop creating our own secret list and share our list. So don't keep, it's all of us in this room, and for me, the infrastructure we have is 211 and Eden INR. I'm personally, you may disagree with me, committed to making sure that that's where we centralize information. We got to stop competing, we got to start sharing, and we got to support Linda on the Dahlia project to make it easier to apply for affordable housing.
Yes.
Hi, my name is Lois Snell, and I'm a real estate broker and been in this business almost 30 years. I wanted to ask Josh, well, maybe this isn't for Josh. I have a question first. And the question is, you know, you speak about building a lot of senior homes, but you're focused on SROs, right? And I'm wondering, why can't we build some for dual occupancy? And have we thought about that? Dual occupancy. That's my first question. I'm not done. Now you're not going to get it back. Yeah.
So
that was a question. But my primary reason for standing is to talk to you about shared housing. And I thought you had mentioned something about shared housing earlier, but we have a nonprofit, and we're running a shared housing program. And the shared housing program can help a lot of these seniors, especially this lady right here. I was thinking about her specifically because she has a 3-bedroom home, and she lost her home because she wasn't able to afford it. If she had rented those rooms out to another senior, perhaps she would have been able to keep her home. And that's what we work on. We're working towards our shared housing program. And I'm wondering if there is a assistance or some kind of subsidy that could help us with our outreach. And it's just a matter of telling people. It's been very well received, our program has. We just started doing it because we found that there's just a need out here. And you'd be surprised at the number of people, seniors especially. 30% of seniors in this area live alone. And if they just had, you know, $1,000 sometimes would make a big difference in a senior's life. And it could help the homeowner, and it also helps the housemate, whomever that is, and both of them would benefit. Then he or she would have companionship, she'd have security, she'd have someone checking on them daily. All kinds of benefits with shared housing. Okay. Thank you. You want me to get
Jim
off my
Acosta
soapbox?
moment here.
You are absolutely right about shared housing. We are building affordable housing across the county that is not just SRO, but family units and even units where the senior and their family can live together. And shared housing, people are trying entrepreneurial and innovative things because all of us are seeing this crisis unfold in our neighborhoods and our communities with people we know and love. So we're all working. We know the things to do. Shared housing is a thing to do. It's one of the right things to do. And so at the risk of sounding like a broken record, It's not what to do, it is the scale at which we need to do it. We need lots and lots of shared housing, we need more SROs, we need more family housing where seniors can age in place with their family members. We need seniors to be able to live together. And we are doing all of those things now. We are just not doing enough of it yet. And so we need to keep scaling up, and we need to invest and create resources where our hearts are. And if we believe that housing is a human right, then we've got to open our pocketbooks as taxpayers, and we've got to get out our signs as advocates and shake them in Sacramento and in Washington and here, and get the investment as an economy and a society in creating enough housing for all people, regardless of their income or healthcare conditions. And we aren't there yet, and we will only get there if all of us keep saying that's where we intend to be.
Thank you.
I just wanted to say, for the housing that is available, it's also people, if you're applying for housing, thinking creatively. And we have a housing clinic, and there are times when you will see two bedroom units, 3-bedroom units coming up, because there's not people applying for them, and talking about the fact that you guys are part of a community. Pool your resources together. So have 2 or 3 people that you know that you can hopefully get along with somewhat to say, apply for that housing. It doesn't mean that one person has to be in one unit, because that takes longer, but if you're willing to pool your resources, you can get through the process quicker. And we've been able to find that works, and we've had people that have been housed that way.
My name is Christine Sevier. I'm an advocate with Creating New Hope. I have more of a statement that I'd like to say about being creative. You talked about being creative, and I was wondering if there was a possibility that after the respite stay, if there was any strategies in place that we can help the smaller RCFEs stay compliant and house people at a discount by offering other supported services to them to keep their business running and keep their beds full, like staying compliant with licensing, training their caregivers, because they have to pay for all that, maybe giving them a certain tax break. I think we should be creative in helping these small businesses stay afloat because they're doing a good work taking care of our seniors. And if we can just get 1 or 2 beds out of 1,000 of these RCFEs, I think it could make a great impact.
Thank you.
Yes, amen to that.
Yeah, we agree.
Okay, Greg Garrett, Alameda Health Consortium. We represent the 8 community health centers in our county and our region, serving 300,000 individuals annually. I 100%, I was an old affordable housing developer, built senior affordable housing and Center for Elders Independence. So I've seen these issues. One of the things that you have said is housing is a right for all. And we in the healthcare industry feel that healthcare is a right for all, but eating is also a right we all should have. So going back to CalFresh, specifically, here's the question. Why, maybe, suggestion more than question, maybe we should be going on a legislative approach where CalFresh is you're automatically enrolled. If you're Medi-Cal eligible, 98.8% of Medi-Cal individuals are eligible for CalFresh. Why isn't CalFresh a right that people are automatically enrolled in, and we have state legislation that would make that a right rather than a cumbersome, I don't know how many people know this, but the cumbersome process of having to enroll in CalFresh and then the renewal process. And I know that our eligibility and enrollment officers here today, Jerry McGee-Tyner, when someone is eligible, we're at an average of $230 per person. And when you were talking, Robert, about that extra $300, if they're getting those funds from CalFresh, they then can take those dollars that were going to food and put it to rent, put it to other services. So we're very, very supportive, and thank you to Stephen over there at the food bank. We should make CalFresh a right, and it should be something that is eligible people are automatically enrolled in.
Rig, I don't recall the particulars, but I do know that there is a set that if someone applies for CalFresh, the state automatically sends them a Medi-Cal. Let me finish. Automatically sends them a Medi-Cal form because you are essentially deemed eligible for Medi-Cal if you are eligible for food stamps. Your question is, why can't it happen the reverse? Now, there was legislation that made that happen. So my response to you is, of course we can advocate for that. I think like most things in life, if you don't ask for it, you're never going to get it. And so I think that's something that we as a community, and certainly perhaps working with the county overall, can figure out, could that be part of a legislative platform for the county? And then, can it start in Alameda? Can it be regional with all of the other Bay Area counties? And then, quite frankly, statewide. So absolutely it's possible.
I'm there. We're there.
Yeah.
One more question over here.
Hi, I'm Nancy Salome from Crisis Support Services. And, you know, we talk about the homelessness right now and not having enough housing. And I'm wondering if we're thinking about the upstream model regarding the trajectory of the future for the aging population, and especially the aging population that's not going to have enough money for retirement. And so we are, you know, it's out of control now, and I think, where are we going? So that's my thought, concern.
So I wanted to say something a little bit about shared housing and maybe get to your question, Nancy. So it was in this very room that I was in a training about leadership around equity and opportunity, and I was saying we need more affordable housing, and the leader of the course comes up to me in the break and says, Robert, you're really interested in homelessness and you think everyone deserves a home. And it's like, yeah? So I was expecting her to tell me there was something wrong with that. And she said, well, you know, there's enough empty rooms and apartments in the whole state to ensure that everyone has a place to sleep at night. And I looked at her and was like, wait, that's not right. But if you actually really dig down, the truth is yes, there is. We certainly need more construction. We need more affordable housing. But, and I know in terms of messaging, we talk, the solution to homelessness is really housing, but I think there's a thing we're missing. It's about connection. It's about support, and we need both together. And so the question about seniors, a lot of the stuff that I've been doing for decades around homelessness, I got to build a unit for this one person. Well, that one person has family and friends, a dog that they might want to live with. They might need support from someone else who also is looking for housing. The situation that Tangerine just brought up earlier about the person who'd been in the hospital for a while, that person had a daughter who has a daughter who were also both homeless. We housed them all together. That's 3 less people.
I purposely didn't say that because, you know, you're not supposed to talk about the particulars.
In general, I think that the solution here is people living together.
Right.
So we have to think differently about how are we going to support people to be successful in their homes. So as seniors aging in place, I mentioned this earlier, it's not always about creating more housing, it's about how do we change the way we support people to keep their housing. So I don't know if that gets at your question, but I think there's a mindset that we all have that we need to shift to really address some of these challenges.
Oh, one more question.
Tangerine had one
Can
last.
I also respond to that? I think, you know, this notion that we have sufficient housing, which I agree. The problem is that if we can give people, how many of you are homeowners here? So if you can get a tax break for your mortgage, there is no reason why we can not just subsidize and give people a subsidy on a monthly basis to help pay the difference between the cost of their rent and their ability to afford that rent. I mean, it is really that simple. I mean, we can do all of this stuff, but it sort of infuriates me that, you know, we can have these large conversations about the infrastructure we need to do, et cetera, and all we need to do is help people pay their rent.
Exactly. Amen.
That's all we need to do.
Or their mortgage.
Or their mortgage. Oh, sorry.
Housing costs.
Housing costs.
All right, one last question right back here.
Hi, I'm Nikki, and I'm the executive director of Easy Does It Emergency Services in Berkeley, and we provide emergency backup respites, basically attendant care services for seniors and people with disabilities. And one of the issues that we're seeing is that, one, there are not enough accessible housing for, and when you're talking about seniors, a lot of seniors are now needing to use wheelchairs and have, access issues, and a lot of the housing that's out there are on second floor, third floor, and they can't, even if they could qualify for the housing assistance, they can't actually get into the house, so that's a very big problem. And another issue that we're seeing is that a lot of the clients that we're working with have medical equipment, particularly like wheelchairs and scooters. Either they don't have them and they really need them, and they can't figure out how to access them. We're trying to get people connected with Medi-Cal. It's a surprising number of homeless people that aren't connected with, with Medi-Cal or systems that can help them pay for equipment, but that their equipment is being destroyed because they're basically living outside in weather conditions, and it just takes one, a drop of water to get inside of a power wheelchair, and the chair will be destroyed, and that's like $20,000 down the drain. So there's a kind of no one's really brought up these kind of issues, and I want people to actually really think about this when they're creating housing solutions.
And I do have to cut us off because we're behind schedule, but I would love to bring that thought, energy, those ideas, and the possibility of talking about those issues to the conversations in the discussion cafe. Okay?
Please join me in thanking our panel today.
And thank you to our moderator, Colleen Chavla.